Thank you very much for the invitation to speak here. I'd gladly said yes a few months ago when this was put forward, but my knees are telling me perhaps it wasn't such a good idea. But anyway, so I was sort of tasked with tomosynthesis and how that sort of impacts on our daily working practice and things to consider. So what I'm going to do, first of all, just to give myself an idea and just to give the audience an idea, is to how many of us in the room here actually perform tomosynthesis on a regular basis. So could we have a bit of audience participation? How many people actually do DBT in their normal workforce? So if we look around the room, it's probably less than I actually thought that actually do this. So could we have a show of hands of those who don't, so we can get a balance for everybody to... Okay, the reason why I asked this question is where I'm based in Breasthurst, Wales, in Cardiff, or Breasthurst, Wales in general, we've been very fortunate to have DBT for a number of years now, so we've seamlessly incorporated this into our practice. So that's 6 years that we've had to gain experience using this technique. And then where I am also in the symptomatic environment in one of the local hospitals, this has been a recent introduction. In the last sort of 2 to 3 months, DBT has come along. So I've just assumed that we've all been using DBT, but clearly from what the response we've had from the audience today, it's not all of us. So it's new to some and very familiar to others. So when I was given this topic to discuss, to explore, I had to think to myself, okay, so what do we really want to know about this? So I have to confess, I haven't taken any mammograms for many, many years now, and I certainly haven't done any DBT images. So I had to sort of take a look to see what do we really want to know about this. I can see things from a clinical perspective, but actually performing a mammogram, I have very little experience of doing a DBT mammogram. So the aim of my presentation is I have to sort of briefly introduce the science, just so we know what we're looking at, and what is the evidence for its use. Is there a need to adapt our technique accordingly to incorporate DBT into our normal workflow? I did quiz my mammography colleagues. I bombarded them with questions when I knew I was doing this technique to see what questions they had to consider, what worries or concerns they had with regard to positioning, compression, and also the impact of DBT on our practice. We find that now it's being incorporated into everything that we do. So I've just explored that. So when you're given a task like this, what you first thing is to do a literature search, see what the evidence is out there. And I know that my learned colleagues who have spoken before me have gone into compression and blurring, but there isn't very much on those, particularly in DBT. And also, as I said, I've consulted my mammographer colleagues to see what issues they've raised. Okay. So I've just done a general sort of introduction or definition of DBT. It's a very long-winded one, but I've sort of tried to combine everything in there because DBT does vary according to the commercial suppliers of that equipment. So basically, it is what it says there. It's multiple low-dose images, which are then recreated into a three-dimensional image. So your standard 2D conventional mammography, and your now digital DBT 3D mammographic imaging. Okay, so I've put this slide up, and it has several purposes. So my points are working, okay. So this is your standard one-shot 2D mammogram. And the next one in the center is your 7.5 or your 15-degree swing. And then we move across to the one on the far right, which shows a greater degree of swing. Now that is important because different commercial manufacturers do provide different degree angles of swing. So one vendor, one commercial company might have a dual angle, one might stick with a 15, and there are others which have a greater degree of swing. Now this is important to remember. You need to know what equipment you have because you need to consider if you're doing a 7 or a 15-degree swing, or if you're doing, say, a 50-degree swing, that's quite a difference in time, exposure time, and the amount of time that that woman needs to be compressed for that image to be of good quality. So it's always important to know that because it is relevant to the image that you get at the end of the day. It just summarises there at the bottom that it's low-dose sequential exposure. It's about comparable to a conventional 2D. It's slightly more, but it's comparable. So here I went off on my literature search. Some of this actually has been talked about by previous speakers this morning, and I don't wish to repeat what's already been said. But there's been, this first slide here shows the ones which have been looking into whether we are going to introduce 3D, so that's digital breast tomosynthesis, into the screening programme. And as we heard earlier today, some of these trials have shown that there is an increase in cancer detection rate. But the caveat of that is there are cancers which are detected which can be less significant. Are they the cancers which we want to identify? There are other ones which say that it's a reduction in the false positive recall rate to assessment. So that is, if you have a mammogram and you're interpreting the 3D mammogram, are you less likely to recall someone to assessment clinic because you've had a really good look through the 3D image and you've eliminated any potential abnormalities and you've reassured yourself that this mammogram is normal, especially in a dense breast, which is very difficult to interpret. A really dense glandular breast is a challenge, but this can sometimes help us. So these are the ones, as I said, that are ongoing. They have been mentioned here today, but what was said this morning that we need to await the outcome of these trials. We need a good, solid evidence base to change our practice, and we are going to await the outcome of a good randomized controlled trial before we develop it any further. So we will await the outcome. It's not going to be in the near future. It's going to be a few years down the line, but it could impact on our service at that time if it is deemed to be accepted. Okay, so I have moved on to other areas of research in tomosynthesis, comparing if it is going to be introduced into screening, will it then be introduced into mammographic surveillance? That is a possibility. If it's proven to be evidence-based for that, we could be doing it in our routine surveillance mammograms. We also, there's also some posters actually in the auditorium today which has looked into whether we can assess the margin involvement of specimens, tissue specimens that we've retrieved following wide local excisions, for example, whether we can predict the margin involvement for that. So that's something we're actually undertaking in where I work at the moment as well. Okay, so practice technique, radiographer reflections. I've sort of looked into, I was quite fortunate that I had a base of mammographers who use DBT regularly and were very skilled in this practice, and radiographers who this was more of a novel technique to them. So I could question both arms of those mammographers to see what questions arose. How they incorporate it into their workflow. Does it slow them down in their mammographic practice? If they're doing assessment clinics, does it take them longer to do a DBT? Do they need to put the same amount of compression on for the DBT image rather? And we need to make sure that we're still producing the high quality mammograms that we need to be producing, and that's been outlined in the previous speakers' talks. So the advantages, I felt I had to put this in just for completeness, really. I'm not going to show you any pictures as such, because I want to concentrate on how we obtain the pictures. The advantages are, as I said there, it's great enhanced visualization for the characterization of lesions, good for dense breasts, reducing tissue overlap, and it provides a reduction in recall rates as well in the screening population. It has been shown in a limited way so far. Okay, so any new technique or any unfamiliar technique takes a little bit of time to get used to, and we have to accept that. Will we be able to work as quickly as we have been doing? So I asked this to our new mammographers who are starting to use the new equipment at the moment, and it seemed to be that they didn't need any extra time to do these DBTs. But what does take extra time is changing over the shield guard, and explaining to the ladies that they're going to be compressed for a bit longer than a normal standard mammogram. Some ladies find it very difficult to accept the compression, understandably. So that has to be explained very clearly and concisely that it is going to take longer. And it can be quite alarming if the X-ray tube actually moves during the exposure. If they're not warned about those extra things, it can startle them. So we need to keep them as still as possible. We need to ensure that we are positioning correctly. Now that is important, as been said previously. If we're in an assessment clinic, for example, and we've recalled a lady with a standard 2D mammogram, for instance, if they've got a spiculate lesion in the subareolar region, so that's the anterior part of the breast, and we're doing a DBT in the CC position, for example, just to sort of characterize this lesion better, we need to make sure that we are still positioning the patient in the best possible position as outlined previously, because we need to visualize the area, the index lesion that we've recalled them for, and also to exclude any other lesions there. So it's still important to maintain our standards, and we can use the PGMI or its equivalent to do that. But there isn't anything as such being set in stone for tomosynthesis evaluation. Maybe if it comes into screening, one will be developed, because we need to make sure that we are getting the right quality mammograms. So, a couple of slides ago, I showed you the DBT and the difference in swings. So we've got a 15-degree swing, sometimes we've got 20, 40, and even greater. So that can increase the exposure time. So that can also result in more patient movement artifact or more blur, as Judith was saying. Something that we do, which is important to do, is to look at your assessment images on a good quality megapixel clinically diagnostic workstation, just to make sure that your images are of the best quality that you can before they're sent through to the clinic station. Okay, so I went and looked at the evidence into breast compression and thickness and the relevance to DBT. And there isn't really much out there about it, and there is a bit conflicting. So I have one paper here, which, okay, it was a reasonably old paper, but it does say that breast compression and tomosynthesis can be reduced without negative effect to the image quality. But if we're going on to what compression was said earlier, you can compress the breast to a certain thickness, and that's enough. So, for example, do you want to mimic the compression for the first mammogram and repeat it for your DBT? Maybe that is good practice. Do you need to reduce the thickness of the breast if you're taking sequential images through it? There's very little evidence actually out there to compare that, so I think that's definitely something which could be explored in more depth. Some evidence does say actually that you need to still put the compression as much as you would for a normal mammogram, but bearing in mind a 50-degree swing is a long exposure time, it's a long time to be compressed. So you have to be very careful in applying the right compression for the right woman, because everybody's breast is so different. Okay, so we've talked about screening. We've talked about the assessment images, so I'm going to talk about, just briefly touch upon the tomo-guided biopsy. Could I ask the audience again, I know I'm asking a lot of you, how many people do tomo-guided biopsy? Okay, so that's quite a lot of you in the room. That's really encouraging, actually. So we normally default now to tomo-guided biopsy for most of our stereotactic biopsies. That's our default setting now. And there's this paper that was written down there by one of our Welsh colleagues, Simon Hull, back in 2016, who came to these conclusions that tomo-guided DBT was as good as, at least as good as, the normal standard 2D conventional mammography. And there's also a very good poster down in the exhibition hall by my colleagues Joy and Kate that's also concluded that it's as good as. But other than that, there's not many other papers which have gone in to investigate this. I know there's some ongoing, so we'll await the outcome of that as well. Okay, so moving on to questions raised by the radiographer colleagues. I've sort of highlighted them all here. A lot of them mentioned they were a bit unsure of the terminology. Now, the terminology such as intelligent 2D, synthetic view, C-view, combo, they're more related to the manufacturer's sort of trademark names. So let's choose one, for example, synthetic view. Synthetic view is, or an S2D. It's sort of a conventional 3D tomosynthesis mammogram, and from that an artificially created synthetic mammogram, set of mammograms are produced. So therefore you don't need to do your standard 2D and then your 3D on top. You can get that all encompassed in that one exposure. Another thing, oops, gone back too far. Another thing was the compression. I've already raised that we need to do some more research into that. Another question that they asked was, do we still need to do spot views? Our practice suggests that sometimes spot views are very helpful, and there's nothing more satisfying to a mammographer to do a spot view of a tiny spiculate lesion, nice and coned down, and you've got your spiculate lesion right in the middle of the paddle. That is really satisfying. You think, yes, oh, that's really nice. And equally, there's nothing more satisfying for the responsible radiologist to look at that spot view and think, yes, that confirms a tiny lesion, or yes, that reassures me there's nothing there. So we still need to do compression views, and we're very skilled at doing those, but are we going to become de-skilled in that technique? Because if we're going to just tomo everything, are we going to lose that art? But I don't think we will. I think there are instances where we need to still keep doing those to reassure us. Difference between the angles of swing, which one, but it depends which commercial provider you have for that. Some allow you to select a 20 degree or a 40 degree, so that's a standard resolution, or a more higher resolution, so you get different exposures at different times over different angles. And that's something which is normally decided by the protocol of local protocols. Have I missed any out? Exposure times. Exposure times, as I said, do vary with the DBT. It depends what angle you've selected. That isn't up to you, but that's something we need to consider. We want good quality images. We don't want the client to move in that time, so we need to apply the appropriate amount of compression for that. Okay, so NHSBSP, we do include DBT as an additional image in our triple assessment process. As I said, we still do spot compression views, and we now do tomo-guided biopsy. So, the use of DBT mammography screening, the jury's still out on that. We will await the outcome of that, and we will do what we need to do when the time comes. Triple assessment, it sits in place there with our additional mammograms. Tomo-guided biopsy, that's still an additional tool in our assessment kit, and it's just as good as what we've been using previously. Some say it might be better. DBT is very good in wire-guided breast localizations, for example. If we have a very subtle distortion, we can only see on one view. We've popped a wire in there under ultrasound guidance, for example. If we do a DBT with the wire in place, it can reassure us if the wire is right next to this subtle lesion. As I said, we also do specimen X-ray imaging to see if there's any margin involvement, and surveillance mammography. We will wait the outcome of the trial to see what happens there. So just to summarise, we await outcome of research. We need to have that firm evidence base. DBT is becoming more incorporated throughout the cancer journey, throughout our mammographic practice. So will 2D be a thing of the past? Who knows? If we only had a crystal ball, we wouldn't do lots of things. So mammography practice continues to evolve and advance, so we need to make sure that we use everything in our toolbox to make sure our quality is optimum from the evidence we've gained from all the research there. But I think we need to do more research in this area, definitely, to get more answers. Okay. Thank you.
Thank you, Helen.